Thank you, Heather. Thank you for this opportunity. Thank you, ASHI, for organizing this. It's a timely discussion that we're going to have. Those are my disclosure, again, non-relevant to this presentation. Well, I guess we all know the role of HLA in allograft survival, but nevertheless, let me show you some. Here is the early and late rejection in what we could agree that is the ultimate setting, which is related living donors. Those are siblings. ABDR mismatch, as you can see, how 0 versus non-zero is significantly causing early and late rejection. And you can see as you increase the mismatch in the siblings that the risk for early and late rejection increases proportionally. And you know that the HLA molecules have a ton of similarities, but they are different from one another for few or many polymorphic sites. Those are the yellow patches you see right there. This is where the amino acids are different between the recipient's HLA and the donor's HLA. And what is different in the HLA molecules is potentially immunogenic. And those differences can be picked up by the host immune system and lead to cellular humoral rejection. And the mechanism, the cellular players and those cells that detect those differences and do something about it are T and B cells. T cells will recognize mismatched peptides presented by the recipient APCs. Some of them will turn into follicular cells and move to the spleen. B cells recognize the intact HLA antigen through the epitope, and the B cells will become activated and move to the spleen as well. In the spleen, and specifically in the germinal center, T and B cells will connect to each other. This is the T-B cell crosstalk. And if this crosstalk is efficient, there will be maturation of the B cells into plasma cells, a generation of antibody. And now we have T cell, cellular and humoral activity against the organ. And these days, as you know, there are ways for us to calculate this risk. On the T cell side, we always have had PIRCHE T2 specifically these days. And on B cell size, we have the applet mismatch. And I'll show you in a little bit the PIRCHE as a calculator for B cells as well. So today we're gonna focus on PIRCHE in particular. And we're going to go through all the modules that PIRCHE has. And actually, I will show you a sneak peek to something very, very interesting that is coming up in the pipeline of PIRCHE. So, you know that more the antigen level, what matters is molecular HLA compatibility. So it's the difference at the molecular level, at the amino acid level that exists between a patient and a donor. And this method allows you to quantify those differences that, as you know, are all potentially immunologically relevant, immunogenic. And here is a very easy example where, you can put a patient and two unrelated donors, and from the antigen standpoint, they're going to look like identical, right? They're all one DR mismatch to the donor. So in the past, what we have done is to pick one of them to go to each other. But it's easy, very easy for me to prove that actually donor 1 is 80% more similar to the patient as donor 2 is. And because those similarities is what prevents the rejection, probably this patient should have been transplanted with donor 1, given the possibility, of course. And you know that there is not a link between the HLA nomenclature and how similar HLA molecules are, because the nomenclature is unrelated to when they were discovered. But from the molecular standpoint, if you look at A1 versus all the other HLA-A in your screen, you can see that there is absolutely no correlation as to closeness in numbers and how similar molecules are. And there are plenty of evidence out there that link these polymorphisms to humoral and cellular rejection. So these days, there's no excuses anymore for us. We have ways to calculate this. We have a way to calculate the probability of CD4 T cells to be activated because they detect mismatched HLA peptides. And as promised, there is this new module that PIRCHE has, which is the PIRCHE-B, that allows you to calculate the molecular mismatch at the level of the B cells. So this applet or epitope, if you wish, a binding of the B cell receptor on intact HLA molecules. So what is PIRCHE? So PIRCHE is an algorithm that allows us to predict activation of T cells. Historically, PIRCHE has been the predictor of CD4 T cell activation, but as I show you, now you can also calculate the B cells. We're gonna have to do a little bit of legwork before we get into the modules. So I wanna discuss a little bit of foundation about PIRCHE. Because apart from the estimation of the activation of the CD4 T cells by presentation through MHC2, there are a few things that we need to discuss before we dive into the modules. MHC restriction is very significant. What is presented to the immune system is the only thing that the immune system can react to. Any peptide has the potential to activate T cells, and the original location of those peptides do not really matter. And we don't have to forget the maturation of B cells into plasma cells has consequence of being presented something derived from a protein is T cell dependent. So point number one, what happens in the periphery is that the T cells, right, see a mismatch actually peptide presented by APC and get activated. They move to the spleen, as I told you. In the spleen, the T cells will see another peptide, but this time it's presented by activated B cell, by plasmablast in the spleen, right? Key here is that the peptide from these these 2 points comes from the same molecule. This is the link recognition that was discovered by Antonio Lanzavecchia. When that happens, the T cells and the B cells start doing a crosstalk, which sends the B cells into maturation into plasma cells and antibody. And what these two mechanisms are linked to is this MHC restriction. So the capability of the MHC to present non-self peptide. And this is what the wheelhouse, this is what PIRCHE does for us. I'm sure that you have heard all these risk epitope, two mismatch, one DSA, immunogenicity. Those are incredibly important topic about the risk that this mismatch peptides has to the allograft. But we need to discuss the fact that all epitopes are probably risk epitopes, right? Whether they are epitopes as we define epitopes, which is like a binding site for IgG in the HLA molecules, or peptides that derive from mismatch, all HLA antigen, all of them are potentially immunogenic. It depends how they are presented. That's where the MHC restriction is very important. Scenario that I love always to speak of. You got a donor that is DQ7 homozygotes, and you have 5 patients to match, to 5 potential candidates to match this donor. You want to know which one is the best, which basically you're asking yourself how many non-self DQ7 peptide can be presented by the DRP1 of these 5 candidates. And through PIRCHE, you can calculate that the DRP101 can present actually 31 peptides, whereas the DR17 can only present 9 of them. So the DR1 patient is a higher risk presenter. It's very good at presenting DQ7 versus that 17 is much less. So if you have these donors and one organ is transplanted on the DR1, the other organ is transplanted to the DR17, there is the possibility, especially if there is no compliance, that the DR1 patients will develop DQ7 antibody versus the DR17 does not develop DQ7 antibody. This is exactly what PIRCHE can do. PIRCHE can give you the probability, the risk that this is occurring, given the capability of the host immune system to present this non-self. But also, it doesn't say much about the immunogenicity of the DQ7, right? Because the DQ7 in this case was not presented under the same circumstances, right? So if your interest is to try to figure out immunogenicity, you have to make sure that you're comparing apple to apple. This is not the same immunological risk. The other point is that there is a difference between peptide and epitope presentation, right? So the B cell, through the B cell receptor, binds an HLA antigen at the epitope level. The T cell recognizes a non-self peptide restricted to an MHC molecule. Now, it's obvious that the epitope must be expressed in the cell surface of the molecule. But the peptide must only be recognized as non-self, regardless of which one was the physical location before the peptide was created. As you know, when an HLA protein is processed by proteasome, into peptides. Those peptides will derive from any position in the HLA molecule. Some of them will be self, some of them will be non-self. This peptide will be shuffled through the trafficking of the peptides inside the cells and loaded into either MHC1 for presentation of CD8 or MHC2 for presentation of CD4. And the origin, the physical location of this peptide in the initial molecule does not really matter. Here is the cartoon that shows the activation of CD8 T cells from a peptide that was expressed in the surface of the HLA molecule. When these activated T cells goes to the organ and sees this peptide presented in the context of the self-MHC, so this is MHCs that are presenting self-peptide. If the activated T cells will recognize that peptide, it will be sent into killing. Here is a cartoon of a CD8 T cell that is activated by a peptide that was not exposed in the cell surface on the molecule. When this activated CD8 goes to the organ and sees the peptide in the MHC expressed by the organ and recognize that peptide as non-self, will be sent into killing. So there is absolutely no difference as to where the peptide is. All right, let's move into the modules of PIRCHE. So after you log in into PIRCHE, on the top right corner, you have that SOT clicky link. And if you click on that, you see these four modules. And we're going to go through one by one to see what they do and what's their utility. Let's start with donor selection. So this is the situation where you have a patient and a donor, you want to compare them and know what is the PIRCHE score by T cells and by B cells, and so kind of predict the risk. Allele-level HLA genotype is entering the system. You can do that manually. You can copy and paste. You can import, and there are several ways in which you can do that. And at basic, the clinical modes of PIRCHE T2 consider A, B, C, DRB1, and DQB1. But you can switch that to lab mode to do the calculation with all the loci of the HLA. And the reason why there is these two differences that PIRCHE, rightfully so, feels that there is enough evidence to link A, B, C, DRB1, DQB1 to an outcome, whereas there is much less 3, 4, 5, DQA, DPA, and DPB. And I feel that I've seen plenty of cases with DQA or DP antibody that didn't lead to any rejection, and things are kind of murky with 3, 4, and 5. So, but you can switch in either mode and decide which one, how much analysis you want to do on your pair. The step of the algorithm is very simple in a way. Step one, how many peptides can you form from an HLA molecule that are not present in the self-HLA, so they're non-self peptide. And step two is the restriction. Which one of those peptides that are non-self and derived from this HLA molecule can actually be presented in the MHC of the recipient, and for those that you can load and restrict in MHC, the calculator gives you a score. And this is what the report looks like. You have the HLA of patient and donor, where you see in red is what is mismatched. On the right-hand side, you have the total PIRCHE2 score and the total PIRCHE-B score. And below, you can see the locus-specific PIRCHE T2 score and PIRCHE B score. So you can see the contribution from HLA A, B, DRB1, and DQB1, all the loci, if this is what you want to do. And you can actually dive even deeper if that is the case, perhaps if you want to do some study, or if you want perhaps to link a particular allele into the generation of a response, such as like an antibody-mediated rejection, de novo DSA. You can dive in and see, for example, for the presentation on DR17, which is like MHC2 of the recipient, you can see the individual contribution from each and every one of the mismatched HLA alleles in the donor. As you can see here, the 1602 contributes with just one peptide versus 8001 has 9 peptides. You have the list of the peptides right here. You can really dive deep to try to figure out what is the consequence of this mismatch. The other module is this donor allocation. And this is the situation where you have one donor and multiple candidates, and you are tasked to figure out which one of the candidates has the lowest PIRCHE2 score and therefore is a better molecular match. So the tools works the same way. You enter HLA of the donor, you enter HLA of the recipient. You have a bunch of results that you see right here. And of course, also here you can dive deep by clicking on the this folder. It's going to give you the total PIRCHE score and the logo specific PIRCHE score. And of course, if you scroll down, you're still going to have all the granularity that I was talking to you about before, where you can see the individual contribution from each and every one of those alleles. So you can see which alleles might be more immunogenic or providing more mismatches that can lead to an immunological response. RAMP. RAMP is the risk profile module. And so it's a module that is intended to figure out for a particular candidate what are the probability of finding low molecular mismatch donor, or it just give you a snapshot of what it looks like in the population. Those are the graphs that you get from doing a ramp. So it starts with entering the HLA of the patient, and then once you ramp it, it gives you like a bunch of graphs like that. We're gonna go through those so you can see what they mean, and also how do I perhaps use, which is just my way, doesn't have to be necessarily your way. The first thing I want to tell you is that you can change the population. So PIRCHE has several ways to score these. You can do by an NDP, you can do by your PTN, and you can do the combined NDP or by population, and you can do by region. And I did connect with PIRCHE to recommend to do a combined OPN calculator for population. So you could do technically your ramp, your score of for your patients for technically like local offers versus national offers. This is what the graph means. In point one, this graph on the left-hand side is telling you that for this particular patient, more than 50% of the donor in the population that you have chosen has a PIRCHE-T2 score between 48 and 92. The graph in the middle tells you that the average donor out there in the population that you have chosen is 51. And the graph on the right is showing you the PIRCHE2 score by HLA locus, where you can see, for example, for this particular patient, that the highest contribution to the PIRCHE score comes from HLA-A, and the lowest come from HLA-DRB1. And those could be important information for you to know when you have to answer certain questions about probabilities of good donors out there. How do I use it? I use it to answer the question, is there a better molecular the scenario, which is very typical here, at least at NYU, is that a patient comes in at NYU with a potential donor, right? And the first thing that we do is NGS level HLA genotype and molecular compatibility by both PIRCHE methods, so PIRCHE-T2, PIRCHE-B, and Epler mismatch analysis. And once we send back the results in the medical chart, the medical team often asks, is there a better match for my donor out there, right? And this is very useful for you to answer that type of question, which, as you know, you cannot answer based on HLA alleles and their frequency, because although you can guess that very easily, because there is no link between alleles and molecular differences, you cannot use that anymore. But this still gives you the opportunity of answering the question. For example, if the donor that I did molecular mismatch before has a PIRCHE-T2 score 75, and I have to answer the question of whether or not there is something better. I can say by looking at this graph that this donor is just the most common offer that this patient is most likely to get, right? It's like smack in the bucket of 4892, where more than 50% of donor are. And based on the average PIRCHE score, which was 51, this is slightly above the average PIRCHE score for this patient. So, I mean, it's not a bad donor, because like there is other things that you need to consider to qualify a donor as a good donor. But in terms of molecular mismatch, it's slightly above the average out there. But suppose the donor is PIRCHE score 20, and I have to answer the same question. In that case, it's very easy for me to look by looking at this graph. There actually is much rarer donor as compared to the average that this person will get, which will be between 25 and 92 with an average PIRCHE score of 51. And so it will be easier for me to answer that, and it is easier for me to answer that this donor is less common and probably a much more favorable HLA match. There is another feature within RAMP that is incredibly useful and a better way to answer a question that I'm sure 99% of you have got before or a request, which is for this particular patient, let's avoid previous HLA mismatch. And as you know, as I told you before, HLA molecules are more similar than dissimilar. There is more similarity than differences. And so there is a lot of shared peptides between HLA molecules. And saying that you are not crossing A1 again doesn't work anymore, because there is a lot of sharing of peptides across the HLA-A antigens. So within PIRCHE, this is the ramp. This is what it looked like. Is the patient right here, and those are the graph that I snapshot for you. And there is the ABC, the IDQDB, or as many you do based on clinical and non-clinical mode. And what you can do is to set these the particular alleles as previous mismatch, and PIRCHE will shade it for you. And here I set the 0301 and the 1101 as previously crossed. So this patient has had a transplant with a 301 and 1101. And then that's where you get the TMAM. The TMAM kicks in, which is this color, this purple color that you see in the bar graph. And it will show you which other HLA alleles, HLA-A alleles have predicted T memory. So if your next donor is A31, A31, although it's not the same as 0301 and 1101, it is predicted to have TMAM, and it's because A31 most likely shares peptide with A3 and or A11. But if your donor is A1 or A36, you can see that there is no predicted T memory. So this is really the situation where you can say we are not crossing previously mismatched HLA, in parentheses, peptides, which we forget to say, right? Because the peptide is what drives the immunological response, not the number of the antigen. And you can do this, you can dive deep a little bit more. Say, for example, if your donor is A2, or you have two different donors, you can say the A2, the group of A2 has less TMAM prediction or TMAM as compared to the group 31, 32, 33, and 34. And why is this relevant? It's not much so because we, by any means, use only this information to decide which donor to transplant. That is far from it. But there are circumstances, at least we have had circumstances at NYU, where adjusting induction therapy at time of transplant was something that the medical team wanted to consider. And of course, I have some more scientific basis to provide my medical team in the decision of lowering induction if they're crossing A2 versus A31. Is there risk? Absolutely, because you're crossing memory. There is no way to not have some risk, but certainly it looks like there is less projected memory drive if the new donor is A2 as compared to the other group. So they could be handy, especially for the medical team, because of course that's not, by no means that's my decision. I'm not a physician and I should not have an opinion about treatment of patients, and I think you should not as well. Batch module is the situation where you have a lot of cases to look at, and you can upload a CSV file. You have examples in PIRCHE. So if you go to the batch module, it's going to give you an example of like a batch file that you can upload for uploading hundreds of cases or several number of cases that you don't want to do one by one. Please connect with your local PIRCHE representative if you want to do so, in case you're trying to look back at your population and see the relevance of PIRCHE in your own cohort. All right, we're gonna move a little bit into literature, and PIRCHE has this very beautiful literature compass where you can see the number of the publication is there that relates to PIRCHE and outcome, and all of them in every organ, including stem cell transplantation, indicates and proves that these polymorphic amino acids in the HLA molecule would directly, independently correlated with humoral rejection and cellular rejection. If you want to get your feet wet with this molecular compatibility, I would recommend this paper where we made a point to introduce the molecular compatibility and the use and how the algorithm works, and then finish off with the utility of this in the clinical setting, and all the authors listed before me, of physicians and NYU that already are using this concept. There is a lot of publication there. I'm sorry if I don't include yours. There's no it's not done in purpose. I would probably need another hour just to go through the few major publications on PIRCHE. I particularly like this one because it is important to understand like the power of the tools that you use. And I like this paper because the authors compare the PIRCHE prediction to a physical test on T cell activation, which is the ELISpot. As you know, is this enzyme-linked assay that does these red spots, or hence ELISpot, which is a gold standard test for evaluation of T cell activation, especially in the context of vaccine clinical trials. So it's the gold standard to say like this thing is causing T cell activation. And what I like about this paper is that if you look at the Kaplan-Meier's and the outcome of the Kaplan-Meier's, they are almost superimposable. They're almost identical. So much so that I feel comfortable in thinking that PIRCHE2 is basically an in silico T cell activation assay. And I have done ELISpot. I would rather do PIRCHE than an ELISpot. The other important thing to remember always, which links to the next sets of publication, is that the activation of B cells and production of antibody from a protein, a non-self protein, is T cell dependent. And so the two algorithms together is probably what we should start considering seriously, as opposed to just do one of the two, because the two are linked to each other. Although the activation of each and every one of these cell types is independent from one another, the final step, so the decision as to whether you have antibody production AMR, is dependent on T cells finding the cognate B cells. So we had this idea back then that we need to calculate the two. This hunch was like between Adriana and I, and within this 2022, this initial study where we wanted to evaluate whether or not combining T and B cells gives us a better granularity in the population. So we look at this pediatric heart transplant patient cohort, and we wanted to evaluate the freedom from DSA. So when you look at any cohort, I've done that with other cohorts, it's a repetitive event. You will find a group of transplants where the donor is low score by both T cells and B cell method, and they usually do not form the event. And then you have a group of transplants that were done with an organ that by T and B cell score is high, and those are usually the one that creates the event. And then you find these 20, 25% of cases where the two algorithms do not match. One says that is high, one says that is low. And when we did look about what is the probability of forming DSAs during non-compliance, it was very evident that these cases are less likely to form the event, despite the fact that one of the two algorithms tells us that it's more likely for them to form the event. And this, to me, supports the evidence discovered in 1985 by Lanzavecchia, where the better phenomenon is when you have the best combination of worst case scenario, if you wish. What I'm trying to say is that if you plot your transplant in a scatter plot like this one, where you have B cell mismatch in the X, T cell mismatch in the Y, and you split them by low, moderate, high, whichever score you want, you will always find that population of transplants right there that are classified moderate or high risk by B cells, but at a low risk by T cells. So you always find this group of cases right here, this transplant right here, where it's exactly the opposite. They are moderate or high by T cells, but they are low by B cells. And they are not the same as the transplants in the middle, those transplanted in the middle, the scatter plot. And this concept was picked up by many others. And I'm just showing one of the many papers you can find where they looked at this much larger cohort than the one that Adriana and I looked at, where they were able to divide their population in the same concept that I was telling you before, low, intermediate, and high risk based on the graphics that you see on the screen. And they were able to show, in fact, that by subclinical rejection, clinical rejection, and de novo DSA, there is this intermediate risk is more similar to the low risk than the high risk. And that's incredibly important, right? How is that important? We'll see in a second. This concept was like, I'll show you another paper where they went from 400 and something to almost 5,200 kidneys when they look at the same concept, actually in one of the best database they have known of from the PAIRS consortium, where they have a lot of clinical and immunological parameters. In this paper, they correlated 33 clinical immunological parameters. And they were able to show that as compared to the allele level difference that exists between patient and donor, the molecular difference at T and B cells are independently associated with AMR. And because 5,200 was not enough, PIRCHE did a study on the SRTR with more than 400,000 transplants, where they look at the same thing. This kind of a busy graph, but on the x-axis you have the T cell score, on the y-axis you have the B cell score. This corner right here on the left-hand side is the best molecular mismatch, right? They are low by both methods. The corner on the top right is the worst-case scenario where both T cell and B cell scores are very high. And you can see that the probability of still having a survival graft 10 years after or 20 years after transplants progressively gets worse as you increase both of these two model risks. What's the point of all of this? Like, okay, this is beautiful retrospective data, but if you can't apply it, it doesn't help, right? So let me give you an example of how we intend, and we have done before, apply this concept of T and B cells. I'm sure that many of you in this call participated in the National Kidney Registry and the Kidney for Life initiative, where transplants are engineered to be low risk based on molecular mismatch at the B cell side, so the applet side. And suppose that your patient has this screen, right? It has like these numbers of low and zero applet mismatch. That's easy. Make your pick. I mean, you have plenty to choose from. The medical team is probably going to choose the best, the cream of the cream right here. No problems. But if your patient has this screen in NKR where there are no zero, there are no low, and there is only moderate or high, the way we are still matching this patient is the good old style. Close your eyes, pick one. It's going to be all right. This is where you apply that concept, because the next best choice for your patients is not just one random moderate out there in the list, but it's the donor with the lowest T cell mismatch score by PIRCHE T2, because there are plenty of evidence that the risk for this category is much lower. And I hope this is going to be introduced in NKR very soon. Out of this paper, though, there is a super cool development, and this is the sneak peek that I did promise you at the beginning of the presentation, that PIRCHE is working on, that derives directly from this research that they have done on the SRTR registry, where they look at the 5, 10, and 20 years allograft survival based on the molecular mismatch at T and B cell. And this is in the future, there will be this new module right here. This is called OPM, or Outcome Prediction Module. And hopefully, we're all going to. So suppose scenario, like what is this doing for us? Suppose you have this patient and two test donors, two donors, donor one, donor two. You do the PIRCHE, right? Cool, good for us. But what does it mean in terms of allograft survival, right? Well, once you have these numbers, what do you do with it? Well, the LPM is going to help us with that. So you go to the LPM module and you enter the characteristics of the recipient. So, black, yes or no, intact, yes or no, age, number of transplants. And then you have the scores for the two potential donors, donor one, donor two, starting from PIRCHE 2, PIRCHE T2, PIRCHE B, antigen-level mismatch, previous, whether black or not, age, so forth and so on. I mean, you enter parameters, right? And the module, the OPM, is going to spit out this report. Let me break it down for you. On the top right here, you have the survival probability of 5, 10, and 20 years. And these color numbers right here represent how better or worse these donors are compared to the UNOS population, so the STR population. So what that 0.77 right there represents is that this donor is 0.77% better than the average donor in the SRTR. And on the bottom, you have the performance of this particular donor with the characteristic that you have entered in the screen before. And what these color bars means right there, the rank is basically how do they perform compared to the SRTR population, where negative, so going to the left-hand side, is a better because they rank better than the average. And the hazard, so the risk for your graft survival, comes from this RTR data. So it shows you how bad this could be. And so positive in this case is worse. And so what you can do is to flip, as you can see, automatically from one another in the OPM, where you can see the difference. But it's going to give you also this beautiful graph that you can look where you can compare the two donors side by side. And like, for example, for this particular donor one and donor two, you can immediately see that test donor one is better. See the ranking compared to SRTR is on the left-hand side with these purple bars. This shows that these better at HLA-A, B, and the R mismatch and the PIRCHE T2 and B score as compared to the other one. And the other curves, the other bar on the right-hand side, the green one, shows you that donor one is actually better than donor two. And then you can see that for the other parameters, right, age, gender, and so forth and so on, they are very, very similar to each other. What is the projected benefit of this? I've been thinking about it, right? And again, I love always, I don't want to just talk about like, oh, this is cool, but I want to kind of put it in the context of our everyday's life. And I think this module has a projected benefit that is at least twofold. From the HLA laboratory director perspective, right? When I'm asked the question, which one is the best donor for our patient, which by the way, I found it very loaded because there's no way I can possibly know which one is the best donor because I cannot see the future. But in this way, I have a more scientific way to answer what probably is the more appropriate question that we should get from the medical team, which is which donor has the lower or lowest molecular mismatch. Moreover, this thing is going to help me avoid the question to begin with, right? I do not have to answer the question. I just have to run the report. The data will speak for me. And so from the medical perspective point, the report will give the medical team an answer that is in line with their clinical practice of what they always do is to correlate a biomarker to a published reference. to link that biomarker to a clinical outcome, whatever the clinical outcome that they're looking for. So this is a language that the medical team can easily digest. So I think that this module is going to load off some of these unreasonable questions that sometimes we have from the medical team, where they want us to predict what is going to happen 20 years from now. What this module can tell you is exactly that, can give you what is going to happen, when it's going to happen, and why that is going to happen. Um, the only risk-free cutoff for our patient would be zero, and ideally is also a genetic match to the recipient, so they're identical siblings. Under any other scenarios, you will be crossing immunogenicity, potential immunogenic differences. Again, I do not know which one is the best donor. If you get that question, I should push back. The only thing you can say, you can quantify the difference for them. And that's where I think, in fact, the OPM model is going to come on handy, because the OPM model is going to be me on point one, quantify the difference. On point two, it's going to tell the outcome. And again, this speaks for me. I do not have to have an opinion. I'd rather not have an opinion, because I can't predict the future. I just can have an opinion about the present. But because we all need cutoffs, these are the cutoffs that we use at NYU. For the B cell side, we still use we do use the cutoffs derived from the Chris Weeby and Nickerson publications. The B cell cutoff from PIRCHE, so the PIRCHE B are being investigated currently. So probably in the future, we're going to have like some PIRCHE B scores that we can use, similar to what we do with the applet mismatch. On the PIRCHE side, this is what we use. This is our preference, given a lot of discussion and reading papers that we have together as a team. I don't know if they are correct. We'll figure it out. We have a clinical trial in progress to try to figure that out. But remember, there is always a risk. In fact, donor are categorized as low risk, moderate risk, and high risk. And I put it in yellow highlighted that every one of these categories has the word risk after. So the key here, unless we will magically find immunogenicity, is that the scope here is to lower the probability for the immune system to react against the organs. So it's a risk minimization rather than a risk prevention, unless you can have a fully genetically identical sibling. Clinical application. Two spaces, of course, right? Living donor space, deceased donor space. The living donor space is perfect for engineering transplant to be low mismatch or high molecular compatibility. You flip it the way you want. For both donors type, the other interest that we have is to look into individualized medicine, right? And so both induction, immune suppression, and actually also the way we follow up the patient is roughly blanket. Somebody someday, somehow, has decided to do it in a certain way, and we do the same way for all the patients. But this science is clearly telling us that transplant are different from one another. And we should probably put a little bit of effort in adapting the induction and especially the immune suppression. In the living donor space, unless you are Cutty Murphy and you work in one of the most amazing center that does living donor transplants, your donor pool is absolutely insufficient to pull these off. And so what is best to do is to link in, to share in a network where all the centers put the donor together. So now you have a large enough cohort where you can go into this type of granularity. Important, because this is also another myth out there. Donors are selected still based on the same principle and rules that have governed transplantation since the beginning of it, and in some instances on center-specific standard of care. So by no means donors are selected or shall be selected solely on the basis of molecular compatibility. This is not what is happening. And so the first step in shared networks is for the medical team, no HLA. We have nothing to do with this. The medical team is going to define whether these donors are acceptable medically and surgically for donation. So now you have a bundle of potential donors. You could use any one of them, right? They could pick any of them. All of them qualify equally or very similarly as potential donor for their recipient. At this point in time is where molecular compatibility is applied, where you take this bucket of acceptable donor, you split them among low risk, moderate risk, and high risk, or perhaps zero risk. And whenever possible, transplant are engineered to be in the zero low risk side as opposed to the other side. We teamed up with the National Kidney Registry that created this Kidney for Life initiative in 2020. So NYU and helped NKR establishing this program. And as you can see, since the inception of this program in 2020, the number of transplants that are engineered to be purposely created to be low haploid mismatch is increasing very rapidly. And I just want to point your eyes to this green color portion of the bar because those are compatible donors. They are decoupled in purpose because of a better possibility out there in the network. Below you have the actual wait time to transplant divided by ABO. That was important to us to try to understand whether this was giving like some sort of delay to transplant. Please focus on the red line. This one ABO recipient, and you can see that more than 50% of them are transplanted within the first 2 months of being activated in the NKR network. So it does not look like it's impacting anything. On the disease side, one of our biggest interests is decreased immune suppression. And Dr. Lonze is the PI for a clinical trial where we decrease immune suppression 90 days post-transplant if the recipient was transplanted with a donor, either living or deceased donor, there is low haploid mismatch by B cells, which is what we needed to do for this grant. But we are monitoring also the PIRCHE-T2 score and the PIRCHE-B, so we will be able to see the correlation with those as well. Now, this is an active clinical trial. I cannot show you data for the love of me. I did try, but nobody can stop me from saying that everything looks very, very promising, and it looks like that there is a way into us reducing immune suppression and providing a better quality of life post-transplant. Very briefly, how do we use the molecular compatibility in NYU? And note, when I speak about molecular compatibility, I mean PIRCHE-T2, PIRCHE-B, and haploid mismatch through the HLA registry only. So on the living donor space, molecular compatibility is done every time Doreen and I get a virtual cross-match. There is no instance in which we do not do these 3 things when there is a virtual cross-match on living donors. If the donor says a favorable molecular score, the medical team most likely is going to proceed to direct donation. If it's unfavorable, the medical team is going to discuss with the patient and the donor the possibility of swapping, and they'll take it from there. If they want to do so, they can enter NKR. On the deceased donor size, we do molecular compatibility at time of virtual cross-match, even in the middle of the night. If it's likely to be zero and low, Doreen and I have done enough molecular compatibility that we can see it. There is going to be different, despite the fact that the numbers are different. I think it's important, and we feel, Doreen and I feel it's important to let the medical team know in case they stumble upon a very, very good molecular mismatch, and that could be the reason why they want to take an organ or not. In-chain offers to place on the wait list, we have those, and many of you will probably have it as well. That's a parameter we do. When a change in suppression is needed, any organ will connect with us and ask us for molecular compatibility so they can decide how to change immune suppression as opposed to just decide that today I feel like 5 is better. If there is a reason for different induction that is done as well, retransplants, we love the team memory module for retransplants. We are ready to answer questions when the medical team says, are we crossing previously mismatched HLA? And ramp is done, as I told you, when we have questions about like what is the likelihood of favorable organ offer. But for all the donors in general, we have at least these 4 points. There are many, many more, but it would take me forever to go through all the granularity. But at NYU, we are really chasing the cream of the problem, which is induction, immune suppression, post-transplant monitoring, and also reduction of belatacept. Bela is what stops the cross-link in the germinal center. It's very much used, plenty of transplant centers, they are Bela specific. We convert a lot of people on Bela. Bela has a direct correlation with risk of infection do you need to use full BELA if your PIRCHE score is very low? When BELA is targeting the connection between T and B, that is something very interesting. So some of them are in trial, yeah, the trial in progress, some are phase of planning, but those are the top, again, when I say top 4 topics of interest for us. So I guess with all this blah blah blah, was able to convince you that molecular compatibility is the better way of defining compatibility between a patient and donor because of their very evident correlation with the risk of rejection. And I don't think you need to love it. Absolutely far from it. But I think you can't deny the evidence. And I do agree by any means that there is a lot of work that we need to do to know better about this, but I don't think you should use that as an excuse to not support your medical team when they ask you a question and to provide better quality of care for your patients. And with this, I want to thank you for your attention and ready for questions. Thank you.
Hi, Massimo. There's a lot of questions in here. So I don't think we're going to get to all of them, but we do promise to go in and answer every one of these individually in the upcoming days. I think one of the questions specifically is how does one integrate previous alloantigen exposures, such as pregnancies or previous blood transfusions, into the PIRCHE module? You're muted.
I haven't learned anything, and I've done so many Zoom. Yeah, it's actually a very good question. Yeah, you can do that. I mean, provided that you have that information, right? Most of the time we don't, but provided you have the information, when you calculate either you can calculate the mismatch at those by adding all the donors, right? You're supposed to do donor one, I mean, recipient versus donor one. You can put them all up. But what I will probably do is in the ramp, when you go to do the team M, as opposed to add like the A3 and A11, as I show you, can add all the other HLA that was crossed. Of course, the more you add, the more the team M is going to light up, right? It's the same concept if you do the same thing from the applet perspective standpoint, and you say, I want to avoid all the previous applets, pretty much everybody is going to be 99% CPRA. But at least it's going to give you, I guess, like what I've seen, at least. We had a case where there was a patient that had 3 pregnancy with 3 different partners and 1 transplant and was going to the next transplant. So I had like 4 different crosses, and that you can go to the ground where you say this group of antigen has less TMM than this group of antigen, but most likely all of them will have some TMM.
This one is a little bit longer. So the scatter plot that was shown on slide 94 suggested that a correlation between T and B PIRCHE scores is minimal. Is it true in general that the correlation between the two scores is very weak, or was the low apparent linkage unique to that study?
Okay, so that is a made up stuff to make the point. There is there is much more correlation. So what is low is going to be low. What is high is going to be high. I'm just trying to make the point here. Let's not focus on details. Let's focus on the great point. The point is that what is low will remain low. It's very unlikely for you to have a low B cell score that's going to be screaming high by PIRCHE, and vice versa. If something is high, it's going to be high. Then you have all the borderline, right? All the moderate that I was showing you in the app registry. Those that are moderate by B cell score, at least 20-25% of those will have low PIRCHE score. So though that is essential because that's where you can define the intermediate group, right? Which is not necessarily the moderate group that was defined by Chris Wiebe. It's much more than that. So there's more cases in the moderate risk as opposed to just the few that you can catch by one or the other. And I'm not saying that if you do that with a PIRCHE score, you will not find. I mean, the opposite is true, right? So sorry. I haven't been so precise, but the point was there when I was trying to make a point.
Okay.
I guess I made it because there was a question, so it's fine.
Yes. De novo DSAs are predominantly of the DQ type across most solid organ transplants. How well does PIRCHE 2 results reflect this in real-world pattern?
I mean, very well, according to an incredible number of papers that shows like that direct correlation. I guess even the paper from the French team on a correlation with AMR already proves that on about 5,000 to 200 cases. They are very well defined with 33 clinical parameters, including proved pathology and the presence of a detectable DSA of a certain MFI level. So it is very good. Whether it's going to happen or not, we have absolutely no guarantee. There's absolutely no guarantee that it's going to happen. First of all, your patient must be non-compliant. Second of all, your patient, or let's say that the medical team has to decrease immune suppression. And then on top of it, you don't know whether or not that is going to actually happen. You know, I mean, that's impossible for any algorithm to predict that. Similar to what Luminex does, which is impossible to predict the MFI with the outcome.
And I think we might have time for one more. If you have a patient, class 2 antigen that presents lots of peptide, but the PIRCHE B score is low, would that not be because those peptides are not immunogenic?
Absolutely no, nobody knows that. There are two different things. One thing is the peptide that are non-self that derive from an HLA molecule that was chewed up by the proteasome. The other one is exposed amino acid in the context of a structural epitope that can be bound by B cell receptors, which are IgGs, right? So two completely different concepts. So you can have a lot of peptides and very little applets. That's why you need the two of them, or vice versa. You can have a lot of applets but very little peptides that can be presented. When the two are not balanced, like when the two clones are not balanced, what Dr. Lanzavecchio was able to show is that the best reactivity in terms of activation of cells was only when specific tetanus T cells were cross-linked with specific tetanus B cells. When we're using like non-specific clones, you need a 10 to the 4 more antigen to still create the event. So that actually happens on that 20-25% of cases. And the prediction based on all these papers that I show you is that there is less likelihood that there is degeneration than over DSA.
Well, again, there are quite a few questions that you and I were going to have to answer in the next couple weeks, but I do want to thank you again for talking about how NYU uses PIRCHE in real life world, and want to thank everyone else for attending. And we will answer your questions, we promise.
Thank you so much.